muscular dystrophy. Most of you probably think immediately, muscular dystrophy, don't give, sucks, and higher incidence of malignant hyperthermia. That's probably the first thing that comes to your mind. But let's talk about it in more detail. It's a cytoskeleton dysfunction of the muscle membrane. So the integrity is jeopardized by a lack or dysfunction of one of the many proteins that make it up. Muscular dystrophy, dystrophin, it's in the name, is primarily the protein involved. And with the most common, Duchenne's and Beck's, that's definitely the case, but it can be any one. Any deficit or changes in proteins can destabilize this membrane. This makes the muscle cell more prone to injury, and if it's injured, it's going to lose some of its contents. And there's all kinds of nasty stuff intracellularly in muscle cells that can be leached out into circulation that can cause problems, such as potassium, hydrogen ions, creatine kinase, which can circulate and disrupt organs like the kidneys. It's characterized as a progressive, painless degeneration of or atrophy of skeletal muscle, and then also, in some cases, cardiac and smooth muscle, with no innervation of denervation, which is a whole separate classification of diseases. Alright, so with most of these cases, dysfunction of the skeletal muscle is usually evident as the patient matures. It's not immediate. Sometimes it is in congenital. There's some level of cardiac and smooth muscle involvement. It's not really the primary concern of the disease, but however, it's insidious and contributory to mortality. So most of these patients die of pneumonia, not necessarily muscle weakness, due to aspiration and poor pulmonary toilet. As already stated, succinylcholine is out of the question, contraindicated, hyperkalemia. Halogenated agents are debatable, and we'll talk about that. There's other reasons other than the higher incidence of malignant hyperthermia that you may not want to give these patients halogenated agents. You can't give them non-depolarizers because it's not contraindicated in any sense of the word, but they are more sensitive. So some of the same precautions you would take with myasthenia gravis, you would want to take with these folks too. One other thing to consider that it wasn't in the books is if these patients have a tourniquet, all those things that can leach out into circulations would probably be worse with these patients, or maybe even less extent depending on the level of muscle that they still have. Alright, so there's many different types of muscular dystrophy. You see here I have 3 of them in red and then 2 in black. The 2 in black are more of the benign, no cardiac involvement. The ones in red, fortunately, are more common too, but they're also much more malignant. Duchenne's is the most common and probably the most deadly. It's also known as pseudohypertrophic, which means that muscle cells can be enlarged, but it's not. It's just fibrotic fatty tissue. It's the absence of dystrophin. It's sex-linked, presents in males. Females are only carriers. Symptoms start as early as 2 and advance as the patient ages. Usually very significant symptoms by age 12. Children could have it and not know it for many, many years, and this is one of the reasons why we don't like to give succinylcholine to kids, because of the hyperkalemic response they could have if it's unknown or undiagnosed. These patients will have elevated CK levels, so it almost parallels the course of the disease. As the disease advances, CK levels will trend up, almost to a peak where they hit their zenith, and then there's just no more muscle cell, or much less muscle cell to degrade, and you'll slowly see a trend down in that CK. Becker's is right behind Duchenne's in incidence. It's about 1 in 10,000 people. They have dystrophin, they just don't have enough of it. So it's more mild. However, they do have more cardiac involvement than Duchenne's, which presents earlier, so they'll end up with congestive heart failure prior to Duchenne's. Congenital, this is the one that you'll see and you'll pretty much know almost immediately. It'll be cued in. Patients are born with hypotonia, so they'll present on their APGAR scores, and it'll clue pediatricians in pretty early that this is what they have. And the problem with these kids is they just can't maintain their own airway. They have severe respiratory dysfunction. Limb girdle and fascioscapulohumeral should pretty much clue you into both of those where they present. Limb girdle is slow and progressive. It's insidious. Patients don't usually even know that they have it until the 5th decade of life. And fascioscapulohumeral, also slow, seen usually in adolescence, so earlier than limb girdle. There's no cardiac involvement or CK elevation, and this one's autosomal dominance, can present in females. Alright, so one of the big questions in our field is, do patients who have muscular dystrophies, are they more prone to malignant hyperthermia? Well, a lot of people out there say that they do. That's just one thing that they know about this disease. You don't give succinylcholine, and maybe you don't give potent inhaled anesthetics either because you don't want to trigger MH. Well, it's kind of interesting because patients who have malignant hyperthermia, their deficit in the ranitidine receptor is on chromosome 19. And as we already stated, the problems with muscular dystrophies, particularly Becker's and Duchenne's, is on the X chromosome. So they're in different locations. So why would these patients be more prone to malignant hyperthermia? Is it a true correlation? And here's one research article, Gurney, Brown, and Littman, 2009, in the Journal of Pediatric Anesthesia. They did an integrative review. They scanned the literature, looked at anything that had anything to do with malignant hyperthermia and muscular dystrophies, and were trying to find a true correlation between the two. And they did not find it. They hypothesized that many of these patients that they thought may have had malignant hyperthermia, patients who eventually received dantrolene, weren't confirmed diagnoses. So they were similar features in the fact that patients had higher potassium levels. They had massive releases of creatine kinase released into the blood. They may have had cardiac episodes where they went to heart failure and arrested, but weren't necessarily with the same high fevers and all the same other diagnostic criteria of MH. And you can't use a palatine caffeine contraction test to truly test this because their muscle physiology is not the same. So they did not find an increased risk for malignant hyperthermia as compared to the normal population in these patients. What they did find, concerningly, however, was that they were at an increased risk for rhabdo and hyperkalemia. So the potent inhaled anesthetics were still enough to destabilize their muscle membranes that led to sequelae of hyperkalemia and rhabdomyolysis that could be life-threatening. So either way, they may not be more prone to malignant hyperthermia. That may be a misconception out there, maybe not, but they are still at increased risk for negative outcomes related to this. So it's just one research article I thought I'd bring up in relation to muscular. All right, myotonias, myotonic dystrophy. So just listen to the word myomuscle tone, just clues you into the fact that they're not necessarily weak. They can progress to weakness. They have sustained contractions where they can't relax their muscle, so their muscle doesn't relax appropriately. This is why I said in the last briefing that you can't give these guys sucks, because they'll have a sustained contraction. They just can't relax. So the thing to remember with this is that it can affect all the systems. It's multi-system. It affects a certain ion channels. It's a subclass disease where it's many diseases under one. Different channels can be affected, but the same result occurs and the same treatment. There's type 1 and type 2. Type 1 is more common and also more severe. Type 2 is less severe. It usually progresses from distal muscles to the more proximal. A lot of these patients will have pacemakers because it can affect your pulmonary system. It can affect your cardiovascular system, especially conduction. These patients will have AV block, profound AV block, but can also have other types of arrhythmias. They'll have GI problems, low motility, and CNS symptoms as well. All right, so myotonia and anesthesia. So we already said that they can have AV block. So your potent inhaled anesthetics can potentiate that. So just be aware of that. Know their pacer settings. We already said you can't give them sucks. If you do, you're not going to be able to ventilate. You may not even be able to get their mouth open to intubate them. Succinylcholine is not the only drug you shouldn't give these patients. You also can't give them reversal. And if you think about it, if you try to reverse them with neostigmine, they're going to have profound contractions. That just not a good idea. Peripheral nerve stimulators will give you an overestimation, so they're not as sensitive as they normally are in most patients. So you don't really know where you are in that soup. You have an overestimation of where they truly are in their relaxation. They will develop a myopathy over time. So it seems counterintuitive. They have sustained contractions, but yet they're weak, and it's just because of prolonged periods of muscle atrophy from their disease process. They will be oversensitive to your sedative hypnotics, so you want to maybe be careful with pre-meds. Potent inhaled anesthetics are okay. TIVA and regional are advocated. They're at higher risk for post-op ventilation. And you can't use trainer 4 if you're not going to be able to reverse them. If you use muscle relaxation, you don't know really where they are. So when you go to extubate, how do you know that they're going to do fine? So the only thing I can think of that you could do is just be very conservative and judicious with your neuromuscular blockers. You might want to wean them on to pressure support as soon as possible, and then get them onto spontaneously breathing and see what kind of negative inspiratory pressure they can pull. That's going to be your best estimation of where they are. But reversal is unlikely or not a viable option unless we could get sugammadex, which has already been discussed. That'd probably be a good drug for these patients as well.